Good evening, everyone. We'll be starting in just 2 minutes. Okay, good evening, everyone. Thank you for joining us tonight in our Total Joint Replacement in an Ambulatory Surgery Center webinar. Tonight, I have the pleasure of being your host. My name is Christian. I'm the Physician Practice Manager for Memorial Physicians Group, Division of Orthopedic Surgery and Sports Medicine, along with Dr. Daniel Chan, who will be leading this webinar. A couple of things before we begin the webinar, just some housekeeping. For those of you who have any questions, we will be answering your questions at the end of the webinar. Please feel free to use the chat function that is found on the bottom right-hand side. Sorry. Also, this is the first time that we will be offering CEU credits. This is for the target audience of nurses, adjusters, and case managers. The course is approved for a 1 CEU credit hour for Florida adjusters and nurses. The program has been submitted to the Commission for Case Manager Certification for approval to provide board-certified case managers with 1 contact hour. There is a keyword that we will be issuing at the end of the presentation, so please hang tight toward the end. We will give that out at the end of the presentation right before the questions start, and you will have to input this key phrase into the program evaluation Specifically, it's going to be in question number 12. I will also send out the link via the chat at the beginning, and then I'll send it out again at the end. You must do this program eval within 24 hours in order to receive the CEU credit. So without further ado, I'd like to introduce everyone to Dr. Daniel B. Chan, who is our Chief of Orthopedic Surgery and Sports Medicine. He is also our Medical Director of Orthopedic Trauma here at Memorial Regional Hospital, which is the Level 1 Trauma Center. Dr. Chan is a board-certified fellowship-trained orthopedic surgeon who specializes in complex fracture reconstruction, as well as hip and knee replacement. In addition to performing outpatient fracture surgery in the Ambulatory Surgical Center, Dr. Chan was the first and remains the only surgeon in Miami-Dade or Broward County who is performing both anterior approach, total hip replacement, and total knee replacement in an ambulatory surgical center. So without further ado, Dr. Chan, it's all yours.
Thanks, Christian. Thank you, everybody, for spending your Monday evening with us. Hope you guys got a good dinner and maybe a glass of wine to sit back and relax. What I'm going to do is I'm going to spend the next 30 to 40 minutes just talking about hip and knee replacement in general, and talking about how the process of hip and knee replacement has really been revolutionized over the past even 5 to 10 years into what we call rapid recovery joint replacement protocols. And then finally, to talk about our outpatient surgical center experience, where we are now able to do hip and knee replacement in an outpatient center where patients are going home within a few hours and doing as well, if not better, than having a surgery done in the hospital setting. So I do encourage questions. Obviously, I'm not going to be able to cover every last detail in the next 30 minutes. So if you pull up the chat window at the bottom of your screen, you can type in a question or you can email it to Christian, and I will address everything once the talk is over. I know we have a pretty diverse audience today. We have people from all over the state, maybe even other parts of the country. I know we have some international people. We have some potential patients, some family of potential patients, and some nurses, and maybe some insurance folks, and some case managers. So I'll try to be as broad as possible, and that'll allow for as many questions as possible. So a little bit of a quiz. So how many people in the United States undergo hip replacement surgery every year? And you look at those choices, and the correct answer is 325,000 people. It's a big number, and it's only going to go up as more and more of the baby boomer generation enters their 60s, 70s, and older. With knee replacement, knee arthritis is actually a more common problem than hip arthritis. So almost pretty much double the number of knee replacements are being done in the United States compared to hip replacements. And the number one cause of disability in the United States is actually arthritis. It's not heart disease, it's not cancer, it's not diabetes, it's arthritis. And so this is a big problem for our population. And so whatever we can do to optimize patient outcomes, to make patients do better, it's going to be certainly better for the patient, but if you look at it in totality, better for society as well. So I do want to kind of go over some really basic things about hip and knee arthritis. So the normal knee, the knee is the largest joint in your body. It's often referred to as a hinge joint because you can flex and extend the knee, but it's much more than that. It's a very complex joint. So as the knee moves, it also rotates and it glides or translates. So it's a very complex motion. And the stability of the knee is achieved through the multiple ligaments and tendons you see in the picture on the right. In terms of the bony structures, you have three main components: the femur or the thigh bone, the tibia or the shin bone, and the patella or the kneecap. And those are the main components we also address in a knee replacement. So when you look at a healthy knee, the end of the femur and the top part of the tibia, they're coated with that smooth, glistening cartilage surface, which allows for frictionless gliding, and that allows pain-free motion. So if you look at the x-ray on the upper right, you see a nice even joint line between the two bones. You see a nice preserved space of cartilage, which is invisible on an x-ray in between the bones, which allows that pain-free motion. When you look at a diseased knee or an arthritic knee, the cartilage space or the cartilage itself has been completely worn out, and that's when you get that classical bone-on-bone contact. So if you look at that x-ray on the bottom, you see that the inside part of that knee joint, there's no cartilage space left, and it's completely bone on bone. It's no longer a smooth line, it's an irregular line. There are some bone spurs off to the side there. And because the knee has worn out mostly on the inner aspect, you can see that the knee is now no longer straight. It's more of a bow-legged appearance. And this is a very common appearance of an arthritic knee. So essentially, what is osteoarthritis? It's really the most common form of arthritis, which simply means inflammation of a joint. And it's also known as wear and tear arthritis. So what happens is the cartilage ends up breaking down, and that causes changes in the joint fluid. It causes changes in the bone. And the key point here is that when you have arthritis and deterioration of the cartilage, that is an irreversible change. So no matter what anybody tells you about stem cells or anything, hocus pocus like that, or some magic elixir or magic pills, nothing we do can regrow cartilage without some kind of surgical intervention. And when you have wearing away of that cartilage, you get bone on bone deformity, you get grinding, you get pain, you get swelling. And the thing about arthritis is that it's going on even in people as young, well, I'm not that young, but people like myself, it's probably going on right now. It's just that it hasn't reached a point where it's symptomatic. So people have arthritis for many years before they first start noticing it. And by the time they notice it, it's already at a pretty advanced stage, and that can sometimes limit what we can do for them. So what is a knee replacement? So when somebody has severe arthritis and they've gone through all the typical non-surgical treatments such as anti-inflammatory medications, Tylenol, Motrin, Aleve, physical therapy, exercises, weight loss, certainly if you're overweight, and maybe even some injections, surgery is a good option if you have quote unquote bone-on-bone arthritis. And so what do? I think one of the most common misconceptions that people have is that we're cutting out the entire knee and we're replacing it. And that's really not true. It's really more of a knee resurfacing. So we basically take a saw and we shave off the worn out ends of the femur, the thigh bone, and the tibia, the shin bone, and we're resurfacing the joint with the implants you see there. So you see the shiny silver colored femoral component. It's almost like a little cap that goes onto the thigh bone. On the shin bone, it's like a little tray with a stem that goes into the shin bone. And then in between the two is this plastic or polyethylene spacer that replaces the cartilage, and that's what allows smooth gliding of the knee joint after a knee replacement. So let's go to the hip side. So the hip is a joint, also has cartilage on the two sides of the joint, which is the hip socket or the acetabulum, and the ball side, which is the upper end of your thigh bone or the femoral head. And I'll try to play this video here. And so the hip is a true ball and socket joint. And so it has a wide degree of freedom, and that cartilage that coats the ball and the socket is what allows that mobility to occur. So what happens when we go from a healthy hip to an arthritic hip? Much like with the knee, that smooth cartilage surface ends up breaking down, wearing out. You have more bone-on-bone grinding. You have bone spurs. So instead of a smooth ball and a smooth socket, it's almost like a wrinkled prune grinding inside, like some loose rocks or pebbles grinding away at that hip joint. And that can cause swelling, pain, stiffness, weakness, limping, and really is a significant source of disability and pain for patients. So again, you can see the differences in the x-rays. You don't have to be a radiologist or an orthopedic surgeon to appreciate that in the upper right image, you see a round ball and a round socket, and you see a very symmetric empty space between the two bones. That is the cartilage. Whereas you look at the bottom image, that cartilage space has pretty much totally been obliterated, and you have the classical bone-on-bone changes. Instead of being a nice round spherical ball, the ball of the hip is now almost like a flattened mushroom or a pancake. And you see all of those bone spurs, those irregular spikes of bone around the hip joint. And you can just imagine the kind of pain the patient on the bottom is feeling and the stiffness they're experiencing compared to the patient on the top. So what do we do when we do a hip replacement? So it's a little bit different than a knee replacement. So we actually cut out the entire ball of the hip. We're not really resurfacing it. That's a different procedure. So we cut out the entire ball, we core out or we smooth out the socket of the hip, and then we wedge in or impact this titanium cup, which is that gray-looking socket. Inside that titanium socket, we snap in a plastic or a polyethylene liner, so we don't want any metal on metal grinding like has been reported on the news and has been associated with poor outcomes. On the thigh bone side, we chisel away some of that marrow inside the thigh bone, and we wedge in a titanium stem, and that becomes the anchor point for the new ball, which is typically made of a ceramic, and that's the pink ball you see in the bottom. And so that ceramic ball now goes inside that plastic or polyethylene liner, allowing for that smooth, frictionless gliding. So now that we have some basic framework to talk about what's involved with hip and knee replacement, let's talk about how they've been done in the past and how we're doing them now. So until maybe 5, 10, 15 years ago, the vast majority of hip and knee replacement procedures were being done as an inpatient procedure in the hospital, meaning you have the surgery, you stay overnight, you stay several days usually, and then after surgery and after maybe sometimes even a week in the hospital, you're discharged to some kind of inpatient rehabilitation facility or a skilled nursing facility, and often people stay there for many weeks. After that, you finally are strong enough to go home, and then you have additional weeks to months of physical therapy. So this really is a very prolonged recovery period. People were experiencing significant pain and immobility for weeks, which is why they needed to go to a rehab, because they couldn't go home directly after surgery because it was just too painful. They were just not mobile enough. And that's what justified having them admitted to a rehab facility. And it took months and months before patients really got back to quote unquote normal. And some never really did, especially with knee replacements, which are typically more painful than hip replacements. Now, when you look at the more modern paradigm, and this is what we do at our surgical center at Cypress Creek in Fort Lauderdale. So now it's an outpatient procedure, not in a hospital setting, but in a freestanding outpatient surgical facility. Patients typically are in the facility no more than 3 hours from surgery to discharge. And if the procedure is done relatively early in the morning, most patients are usually home by noon. And because of some of the things I'll talk about in just a little bit, the requirements for physical therapy are much less. And for hip replacement, which is generally a much quicker recovery than knee replacement, some patients don't need any physical therapy at all. They just start walking on their own and doing their own exercises either at home or in a gym, and they just recover fine without any other assistance. And then when they're in the surgery center, as soon as their anesthetic wears off, then they're walking within an hour of surgery, and the pain is generally tolerable throughout the course of their rehab. And most people can return to normal activities within 2 to 6 weeks. So what are the things that changed between then and now? What are the things that are different? What are the new technologies and new techniques that allow for a rapid recovery joint replacement experience? I think on the hip replacement side, which is kind of my passion, the anterior approach has really revolutionized hip replacement rapid recovery, and we'll talk more about that in detail. There are some newer instrumentation and tools that we use that can help patients recover quicker. There are different things we do with anesthetics, both administered by the anesthesiologist and local anesthesia, as well as pain management protocols after surgery. And also critically important is the care coordination and the patient education. And I know this is an important part for our nurse case managers on the call, is that when you have a client, probably a workers' compensation client who is looking to have hip or knee replacement, setting those patients up for success by setting expectations and setting goals is going to be critically important in getting that patient recovered quickly and back to work as soon as possible. So what is the anterior approach for hip replacement? So the incision for the actual surgery is actually made on the front side of the hip, which is the anterior side, as opposed to the direct lateral or the side approach or the backside approach, the posterior approach. And the main benefit of this approach is that the surgeon is working in between the muscles. We're just kind of going in between the muscles. We're not cutting or detaching any muscles. And that really facilitates a faster recovery. And we can also use other things like a high-tech orthopedic table and intraoperative x-ray, as well as navigation, to really make sure that the implants are being placed appropriately to minimize complications as well as to improve the longevity of the hip replacement construct. So there are multiple ways to get into the hip. You can put the same implant in through a number of different approaches. Traditionally, most hip replacements were performed through a posterior or a backside approach, and that's what's illustrated here in the bottom two pictures. So typically the patient is positioned on their side, and that makes it difficult to get X-ray machines in there to take a picture to see what you're doing. The patient can be rolled to one side or the other, so it's difficult to control how the patient is tilted. And you can see in that bottom middle picture, you have to cut through all of those small hip muscles over the hip joint to get down to the hip. So that potentially can destabilize the hip. It potentially can increase the risk of dislocation, and it can prolong the recovery because now you have to wait for that muscle to heal. And so for people who have a posterior approach, which is the dotted blue line you see in the upper right, traditionally patients were told that they can't sit in a low chair, they can't cross their legs, and they can't turn their legs inwards for 6 weeks until everything scars in, gets tight again, and heals up. When you contrast that to the anterior approach, so now the patient is lying on their back, they're lying supine. And this is an example of the special orthopedic table that we use where the patient's legs are in these traction boots, almost looks like rollerblade boots, and they're in these traction spars. And so we have complete freedom to move the leg in any position that we want. We can also bring an X-ray machine underneath the hip and take a picture to make sure we're doing a good job of reproducing the anatomy and placing the implants correctly. In the image in the bottom middle, you can see that we're going in between the muscles. We're not cutting any muscles at all. One of the more common questions we get is that, well, what if I'm a little bit overweight? Does that make it more difficult to do an anterior approach? And I would tell you that for obese or overweight patients, it's actually better to do an anterior approach because there's less tissue in the way. So if you look at the image on the bottom left, that is a CAT scan image of a patient. And this patient's not even that big. This is probably a very, normal, quote unquote, normal sized patient. But this is a cross section. So if you look at that image, on the upper part of the image, that's their belly. The bottom of the image is their back. And so the blue arrow is what I have to get through to get from the skin to the hip joint going in from the front. And the green arrow is what I have to go through to get to the hip from the backside. And so you can see it's a much thicker distance. And for obese patients, they have much more soft tissue in their backside. And that can be a much bigger dissection and more soft tissue trauma to get to the hip from the backside. So when people come to the office and ask me, am I a candidate for an anterior approach? Pretty much everybody who has not had prior hip surgery is a candidate for an anterior approach hip replacement operation. So what are the benefits clinically for the patients for the anterior approach? So it's a quicker recovery because we're not cutting through muscles. There's less pain. There's less time that patients need to use a cane or a walker, so they're walking independently much quicker. I had patients walk with no assistance within a couple of days of surgery even. While these patients were being done in the hospital, it was associated with a shorter length of stay, but now we're doing it in the outpatient arena, so they're just not staying overnight at all. And they're needing physical therapy and rehab much less. And for the workers' comp crowd, this obviously means a faster return to work. Because we're going from the front and we're not cutting any muscles, we are not destabilizing the hip. And so there's a decreased risk of dislocation. There's no postoperative motion restrictions. I tell patients, you literally can do whatever you can tolerate as soon as the procedure is over. And because we can use special things like computer navigation and X-ray, we can get the implants placed directly where we want them to be. And that means that the hip has a better chance of surviving 30, 40 years down the line, as opposed to if they're put in incorrectly, they may dislocate or they may fail prematurely. And finally, because the incision is on the front of the hip and not on the back, so you're not lying on your incision all the time, it's easier to take care of your incision postoperatively. So what other advanced instrumentation do we use to perform the procedure nowadays? So before, we would use a mallet or a hammer to basically chisel out the bone, to put in the implants. But even as a trained surgeon, every strike of the mallet or the hammer can be very irregular. You may not be using the same force. you may be moving your hand a little bit. So now we've automated this process. So now we have basically an electronic hammer that delivers the exact same energy with each strike, and we can fine tune and adjust how we put the implants with much greater control. So here is a video of me putting in the cup. So that's the socket you see in the bottom left, and we're impacting that cup implant into the patient's pelvis as the first part of the hip replacement. So you can see here, I'm going to play the video. We attach it to the device. You can see I have an X-ray machine up top, and I'm looking at the X-ray image, and I'm putting it in. And you can see it's pounding it in with very little motion from my perspective. And I'm watching the cup go in live on X-ray to make sure it's exactly how I want it. And you can see my hand's not moving hardly at all, so it's much more precise way of doing it. And we use the same device on the other side where we're chiseling out the bone to put the stem in. Again, before you would take a hammer and use these chisels and bang it in, bang it out, bang it in. You know, it's pretty, barbaric in a way. And now it's a much more precise way of doing it. So you can see those are the little chisels or broaches we use to carve out a space in the bone marrow to place our final implants. So you can see it going in. So again, my hand's not moving. I'm controlling exactly how everything goes in and out of the thigh bone. And that is a much more reproducible action. And so basically we use larger and larger chisels until we get a nice tight fit. And that is the size of the final implant we put in the patient's thigh bone. And so another example that you kind of saw a little bit about in the first video was the use of computer navigation. And so the number one complaint or issue when hip replacements go bad is because the leg length was either too long or too short. And before, especially with the posterior approach, it was very imprecise as to how you got the patient's leg back to the same length. You would kind of feel the other side and make sure you got it close, very imprecise. So now with using the anterior approach, using computer navigation, using live X-ray, I can be very precise in the rotation and orientation of the socket. And if you look at that bottom image there, I can know exactly how much I'm changing the patient's leg length by the millimeter. So if I put in a trowel implant, and let's say, right there it says it's highlighted, so I've lengthened the patient 4 millimeters, and I've increased their offset by 3 millimeters. If I like those numbers, then I take that implant. If I don't like those numbers, I can look at that menu of choices and see, okay, what correction am I going for and what combination of implants will get me there? So now it's a much more precise and reliable way of doing things. Patient outcomes are much better because you're getting the leg lengths perfect every single time. There's no eyeballing it. There's no feeling it. It's a much more precise way of doing the operation. So I touched a little bit on the wound care aspect as well. So nowadays, we really don't use any staples or stitches on the skin surface. Underneath the skin, we use stitches that are dissolvable for the multiple layers of muscle and fat and other tissue that we're closing up. But on the skin surface, we're using this skin mesh or skin glue mesh product. So basically, it's a little sticky mesh that sticks on with the skin glue. It seals the entire incision off. It stays on for about 2 to 3 weeks. And patients can shower right away. It's waterproof. They don't have to change the bandages every day. You don't have to have a home health nurse come by every day. So again, for my workers' comp case manager colleagues, you're saving on sending some home health every day to the patient's home. This is very low maintenance. The patient can move around freely. They can wrap it around with an ACE bandage if they want. They can leave it open to air if they want. And this also, I believe, cuts down on infection because you're not exposing the surgical incision to the outside environment. This dressing is placed on sterilely in the operating room and stays there for 2 weeks undisturbed, where the incision is totally sealed off. And obviously less infection is always a good thing. So what about the anesthetic considerations? I know a lot of patients are sometimes much less worried about the surgery than they are about the anesthesia. So in the surgery center setting, most patients will receive a spinal anesthetic. So for women in the crowd, that's the same anesthetic that you would get if you were having a C-section. And it wears off in about 2 hours. The surgery itself takes under 1 hour, so it's plenty of time. And the benefit of that is that you don't have to have a breathing tube or general anesthetic. So there's less nausea, vomiting, grogginess associated with general anesthesia. There's less pulmonary or lung complications associated with being intubated. Right now with COVID, we've learned that intubation is actually a traumatic event. And so intubation may not be a good thing all the time. There's also studies that show that there's less bleeding and there's less blood clots. So it's a slam dunk. It's really a win-win. And so most patients get a spinal anesthetic. They're numb from the waist down for 2 hours. Once that wears off, they start walking as soon as surgery is done. For knee replacements, we also give a nerve block that basically numbs the entire knee down for at least 12 plus hours after surgery. So the anesthesiologist will use ultrasound guidance to target the main sensory nerves around the knee, and they'll inject a long-acting local anesthetic into the nerve area, and that'll numb up the entire knee, again, for at least 12 hours. That really makes it much easier for patients to go home within a few hours after surgery, because again, knee replacement is typically more painful than hip replacement. And it's really quite amazing to see these patients in the recovery room within an hour of surgery. They're bending their knee from 0 to 90 really effortlessly right away. Whereas a lot of patients in previous years were struggling for up to 6 weeks trying to reach that 90 degrees. It was just so painful. And with modern techniques, they're doing it right away in the recovery room. We also do, in terms of multimodal pain management, obviously with the opioid crisis in the country being what it is, we want to use as few opioids as possible. So what are some of the things that we do? So as the surgeon, before we close everything up, we use a local anesthetic injection that we inject into the muscle, into the skin, the fat, into the surrounding soft tissues around the hip or the knee. And that also provides some additional pain relief. But more commonly now that once patients go home, we give them what's called a multimodal pain medication cocktail. So we give them a bunch of different medications, each targeting a different part of the pain pathway, all in an attempt to decrease the amount of opioid pain medications they use. So during the surgery, they get Toradol, IV Tylenol, IV steroids, which can decrease muscle pain and inflammation. When they go home, patients get Celebrex, which is a prescription version of like Motrin or Aleve. They get Tylenol. They have a medication for nerve pain. And then they get a very small amount of oxycodone just for severe breakthrough pain. Or I tell patients, most people have more pain at night, then it's okay to take one at night. Or they can take one right before their physical therapy session so that they can allow the therapist to work more vigorously with them to get a faster recovery. We also give patients medications for nausea, for a stool softener. And because patients are moving so quickly after surgery, their blood clot risk is actually very low. And so we found that just giving an aspirin is adequate as a blood thinner, because if you start giving them more powerful medications, then you have much higher bleeding risk complications as well. So let's get to the meat of the talk. So why do surgery at an outpatient surgery center, right? I mean, for some people it may be new, maybe unfamiliar, you're not quite sure what to expect. The important thing is that the exact same technology, instrumentation, the equipment, and even the staff that we have in the hospital is being duplicated in the surgery center. So the same orthopedic table, same implants, same instrumentation, including that navigation system that I showed, including the electronic hammer that I showed, we all use the same thing at the surgery center. And in fact, in terms of the staff, a lot of the hospital staff actually do double duty and moonlight at the surgery center. So it's really the same team doing the same surgery in the surgery center. And because it's a freestanding outpatient surgical center only, there's no ER, there's no inpatients, no ER patients, no sick patients. It's a much lower traffic area, so it's a much more patient-friendly environment. You have one-on-one attention. You're not packed in with a room with 50 other people. It's a much lower infection risk, and it may be actually lower cost to the patients. Now, I know for a fact that it definitely costs less to do this operation in the surgery center as opposed to the hospital. But with insurance being what it is, and depending on what plan a patient has, we don't know how much of those savings are actually passed on to the patient, but it actually is less to do the surgery in the surgery center. And again, for the workers' comp crowd, certainly that's a consideration as well. And my philosophy on this is hospitals are best suited for people who are sick, who might get sick, or for people who require high-level services. So I'm an orthopedic trauma surgeon as well. If you're in a bad car accident on I-95 or the Turnpike and everything's all banged up and mangled, you want to be in a hospital, right? You want that high level of care. If you're having heart surgery or brain surgery, you need to be in a hospital. It makes sense. But if you're an otherwise healthy person and you just need your hip or your knee fixed, it's not as convincing of a sell. And especially in this era of COVID, the surgery center has really been something that the patients are asking for, because they just don't want to set foot in a hospital if they don't have to. And so doing these procedures in the outpatient surgical center has been really attractive to patients for many reasons. So who really is a candidate for an outpatient joint replacement surgery? So it's generally patients who are under 65 and who have severe arthritis, and they've tried all the non-surgical things. So we don't want somebody who just has a little bit of ache and pain and has very mild arthritis. Those patients generally don't do well with surgery, period. You want somebody who has really kind of gone through the ringer and knows that they've tried everything under the sun except surgery, and they're really ready to have surgery at this point. We don't want patients who have major heart failure or COPD, emphysema, major cardiac or pulmonary issues that might require a higher level of care. We want people who are basically tough, right? People that have lived with this pain for a long time, that they're not dependent on a high dose of narcotics to keep their pain under control. Those patients generally don't do well in a surgery center. So, and people who are active and independent. So I think the best candidate is, what happens is, in my office, I'll look at the x-rays of a patient before I see them. And if I look at their x-rays and it looks like a horrible knee or a horrible hip, and then as soon as I walk into the room, the patient looks like they're totally fine. They're in their jumpsuit, their running shoes. They say, yeah, I want to get back playing golf. I want to play tennis. I want to run, but my hip or knee is just bothering me. That patient is the best candidate for an outpatient joint replacement surgery. And so the last 2 points are also critically important too. It's about patient selection and patient education. So from day one, we have to kind of set the expectation to the patient that, hey, you're a great candidate for this. You're going to go home within a few hours. Don't worry. We're going to take care of you. We're going to have people checking on you after surgery. You're going to do better at home than you are going to be in a hospital. And people that are motivated to really aggressively rehab after surgery. And so nothing happens in isolation. So it takes a lot of moving pieces to kind of pull this off. So it takes a great deal of coordination between my office staff, the office staff at the surgery center, case managers if they're involved. And then once they get to the surgery center, the operating room staff, we all have to work as a team. The implants company representatives that service us, they're part of the team. They help us plan and manage inventory and instrumentation and equipment. The recovery room staff is absolutely critical, because these are the nurses that actually get the patients up within an hour of surgery. They're basically acting as a physical therapist in the recovery room. And then obviously the physical therapist and home health staff, once the patient leaves the surgery center and they're now at home, and they may be getting some home physical therapy for a little bit. Once they're more active, then they're going to go to an outpatient physical therapy for as long as they need. May not be very long, maybe 4 to 6 weeks, depending on the patient, especially for knee replacements. But to get those people involved early on so that they know what to expect, because in South Florida, at least, outpatient hip and knee replacement is still a relatively new thing. And so a lot of people still are unfamiliar with some of the protocols. And so it really takes a lot of people to work together to make this work. And some of the other things that we're even exploring now are taking, especially again with COVID concerns about physical therapy places, we're even exploring the possibility of doing some of the physical therapy virtually and exploring some of the platforms that offer that. And I think that really is attractive to patients who are motivated to do their own recovery and do things on their own. So let me tell you a little bit about our surgical center itself. So it's located in Fort Lauderdale at the Cypress Creek Medical Pavilion. It's a massive complex, 82,000 square feet. There's on-site urgent care, primary care, CAT scan, MRI. There's an Offer Dolls restaurant opening there, hopefully by end of the year. And our department, we're actually building an office with integrated physical therapy directly above the surgery center, and that's opening early next year. So you really have a one-stop shop where a patient can come in and see the physician, get some basic labs, have the surgery, have physical therapy, all in one space. And that, I think, is really attractive to patients. Having everything under one roof, having that convenience, having that communication between the relevant parties is really something that patients gravitate towards. So for those not familiar with the area, this is where it is, that red dot in the middle. So we're right on the northern border of the Fort Lauderdale Executive Airport on Cypress Creek Road between 95 and Turnpike. So we're really accessible. Our dream someday is to just facilitate patients flying into Fort Lauderdale Executive Airport, having their surgery outpatient within a few hours, then they can fly back home from wherever they flew in from. And that's kind of the ultimate dream for what we're trying to accomplish with outpatient surgery. And for those football, soccer fans, we're literally a mile away from the David Beckham Miami soccer stadium at Lockhart Stadium. These are some of the images of the surgery center. So it was designed to be very high end. This is nicer than any hospital or surgery center that I've ever worked at or even been in. Everything's modern, everything's patient friendly. These are the operating rooms. So this is one of the operating rooms that I do my hip and knee replacement surgeries in. And you can see there's the special orthopedic table that we use. And one thing I think you can get the idea is how large these rooms are. Even with that massive table in there, even with the x-ray machine, even with all those instrument trays, there's still plenty of room. And so this surgery center was designed from the ground up to facilitate doing these more complex procedures and even spine surgery procedures in the outpatient setting. If you go to some of the older surgery centers, the rooms are just much, much smaller. They were designed to do like cataract surgery or plastic surgery. So they're just not able to accommodate some of these larger, more complex cases. So what is the typical patient experience when they come into the surgery center? And so we try to streamline things as much as possible for the patients. So we send out pre-op educational information. We always offer the patients to tour the facility if they want to before, so they can get more comfortable with having their procedure done in an outpatient surgical center. We set up physical therapy, either home physical therapy or outpatient physical therapy before, so the patient has a date and a time for their first physical therapy visit before they even have their surgery. We fill all of their medications, pain medications for after surgery the day before, so they can bring their bag of medications with them to the surgery center. So typically, if the patient is the first surgery of the day, they arrive at around 6 a.m. and they are greeted by a one-to-one nurse. So they have, again, very personalized, individualized attention, and we can have them prepped and ready to go. 6:30, we're in the OR. They get their spinal anesthetic, they get their local anesthetic, and then usually by 7:30 or 8 o'clock, again, a hip replacement takes well under an hour, a knee replacement about an hour. They're already in the recovery room. As soon as their spinal anesthetic wears off, they can feel and move their legs. They're up and walking with the recovery room nurse and a walker. And generally by around 10:30 or 11, and for the people that are later in the day, they're gone by noon, 1 o'clock at the very latest, and they're at home. And that afternoon, we try to set up so that they have their first physical therapy session the very same day, just hours after surgery, in home or either at an outpatient facility. And so using these protocols, we really have kind of become sort of a pioneer in the South Florida area. So we were the first outpatient surgical center in Miami-Dade or Broward to perform an outpatient anterior hip replacement using the HANA table. We're still pretty much the only facility that does both anterior hips and total knees in the surgery center setting. We've been doing it for about a year and a half. And I'm going to knock on wood really hard here, is that we really haven't had any surgical site infections, no blood clots or readmissions or fractures or anything that had to be emergently transferred to a hospital. People have done exceptionally well, and I think that's because we've done a really good job of patient selection, patient education, and just really hammering out all the protocols to make sure that everything goes off without a hitch. And the patient experience and the patient feedback really has been universally positive. So some of the feedback that we've gotten from patients, here you can see a patient said, I had my outpatient surgery on a Friday. I went in Friday morning, went home that afternoon, and was walking on my own Monday. Another patient said, I had hip surgery at 7 a.m. and I was home by 1 p.m. I never had any pain and was able to walk unassisted after 1 week. Here's another patient. This patient actually found us online. She lives in Panama City Beach, which is like 9 hours from where we are in Fort Lauderdale. She flew down just to have her hip done at our surgery center. And so she says, I flew down from Northwest Florida just for him. I would do it again. And without hesitation, she woke up without any grogginess at all. And she was getting up, and she's actually coming back for her other side later this year. Here's another patient that came up from Coconut Grove, up from Fort Lauderdale. So she had seen other surgeons locally in Miami. She was thinking of flying to Chicago to Rush University to have it done by a famous knee surgeon there. She decided to stick with us here in Fort Lauderdale. And she said that, she had local anesthesia, no catheter or breathing tube. When I woke up, I was basically walking out, and she was walking in her garden the same day of surgery that afternoon. And then she says, there's no need to fly to Chicago. and which is true. We can do as good of a job as anybody else in the country, and we can do it as an outpatient. So a lot of people are searching now online for their hip and knee replacement surgeon. That's just the nature of the business, unfortunately, or fortunately, depending on how you look at it. But I think based on the positive feedback that we've gotten from doing these procedures in the outpatient setting and the universally positive feedback, that's kind of filtered through all the search engines and the patient reviews and things like that. So depending on where you are, but if you're searching locally, if you type into Google best hip replacement surgeons in Florida, best knee replacement surgeons in Florida, we come up #1 on both. And I think that just speaks to the effort that everybody has put in to try to get this program off the ground and successful. So I think that's pretty much all the comments that I have. I know I've talked a lot, but if you guys want to find more information about us, then that's our office address. You guys can email me directly. I will always respond to emails. My email is right there. It's dchan, D-C-H-A-N, @mhs.net. You can always find us on Google if you just type in g.page/Daniel Chan Ortho, or if we just type in my name, it'll definitely come up. We also have an online link that you can schedule appointments directly. I know sometimes it can be difficult to get into the phone system of a doctor's office, and I'll readily admit that our phones are very busy. So you can definitely email me, or you can click on the online appointment link. And that is the information below for the surgery center as well. And you can find out more about other doctors that work at the surgery center that do other types of procedures. And you can find out more about the facility as well. And so with that, I will stop talking, take a drink of water, and I will be happy to entertain any questions.
Great. Thank you, Dr. Chan. So at this time, I'm going to give out the keyword phrase for your CEU credits. The keyword is sports medicine with a space in between sports and medicine. Again, this will go into the link for the program evaluation, which I've already sent on the chat. So you can feel free to click on that link, and you will place the keyword under question number 12 in the free space. Again, the keyword is sports medicine. And at this time, I will start reading some of the questions. We have a couple questions for you, Dr. Chan.
Great.
So the first one is, what brands of hardware are you using?
Yeah. So it depends. I mean, on the hip side, I pretty much exclusively use DePuy, which is Johnson & Johnson. And that's because they're the ones that have that electronic hammer that I use, as well as the computer navigation. So I use pretty much DePuy, Johnson & Johnson for hips. For knees, I try to mix it up. I use some DePuy, I use some Zimmer, and there are a small fraction of patients who have a nickel allergy, and so the knee replacements are made out of cobalt chrome, the metal components. And so if somebody has a nickel allergy, then I will use a knee from Smith & Nephew, which has a different metal, which is oxidized zirconium for those nickel allergy patients. But I think that I know where that question comes from. I think more important than the actual brand of implant is how it's implanted. So I think a good surgeon can get good results regardless of what company they use. Much more important, because a lot of the implant, they have very similar features. There's not that much difference between one company or other. So I think the technique in which the implant is placed matters far more than the actual brand on the box.
Great. And so there's a follow-up to this question. Approach hardware differs with trauma patients? Question mark.
So in a trauma patient, so someone who has a hip fracture, depending on the kind of fracture, it's treated in different ways. But if somebody has a fracture at the neck of the femur, then we still do an anterior approach for that. And so depending on the patient's functional level and age, so if it's a younger, and I say younger, let's say like 50s to 70s and active, we'll do the exact same procedure that we would do in the surgery center, like a regular hip replacement, a total hip replacement. If it's someone who's older, who's more frail, less active, elderly, we still do the same approach, but we don't do a total or a full hip replacement. We do a partial hip replacement where we just put in a stem and put a metal ball, and we don't do anything to the socket. And that's an appropriate treatment for somebody who's more elderly and lower demand.
Thank you. Next question is post-op DME, CPM, cold therapy units.
Right. So for hips, we don't do anything. Hips just get up and walk. Hips recover very quickly. On the knee side, I believe we are giving patients now a kind of an ice sleeve that circulates ice water, and that can help. CPM, people have really gone away from CPM. Number one, it's expensive. And more importantly, it really has not been shown to improve outcomes. So there are studies that show that if you take 100 patients who had CPM and 100 patients who didn't have CPM, at 6 months to a year, their knee range of motion is actually identical. I actually think sometimes CPM can hurt because in that initial postoperative period, you're swollen, it's sore, and then if you're being forced into this abnormal motion that you're not quite ready for, that actually may worsen the swelling and hurt you down the line. I think patients will just naturally recover their motion on their own if you do a well-executed surgery and have a good pain control protocol in place. And as I said, people are moving from 0 to 90 degrees with no assistance in the recovery room. So if you can do that at time 0, there's really no need for CPM.
Great. Next question. Does the patella always need to be removed with knee replacement?
That's a great question. So even when it is surgically addressed, it's never really removed. Again, it's more of a resurfacing. So if the patella is like this circular bone that's maybe, 3/4 or a ½ inch thick, we just shave, if we're to do anything about it, we just shave off the bottom few millimeters so it's a flat surface of bone. And then we put a plastic button to replace the cartilage. And so that plastic button now glides over the metal femur component. So there are some surgeons that will routinely resurface the patella. Some don't. Some do it selectively. I pretty much do it in pretty much all patients because it can be a pain generator. And so I would hate to have a patient go through all the hassle and pain and difficulty of recovering from a knee replacement, and they still have pain from their patella because I didn't do anything to it. Now, I know there are different philosophies about that. I know some surgeons don't do it at all, but I believe that that it can reduce one more thing that can hurt after surgery.
Great. What is the lifespan for these implants, both hip and knee?
Yeah, so I think no one really knows at this point. I think the main difference with the current generation of implants compared to the ones from 15 years ago is the polyethylene or the plastic. So now the polyethylene is manufactured differently. It's cross-linked. It's much more durable. So a ceramic on a polyethylene hip theoretically can last 30 plus years easily. They're doing retrieval studies where people have passed away for other reasons, and they're pulling out these hips from the people who had passed away. They're 10, 15 years out, and there is literally zero wear of those components. Knee replacements, similarly, I think a well-balanced, a well-done knee replacement on somebody who's not really overweight, who kind of quote unquote takes care of their knee, again, can last 20, 25, or even more years. I would say knee replacements are a little bit lower longevity than hips, only because most knee replacements are cemented to the bone, whereas hip replacements are typically what we call press fit, where the bone grows into the metal. And so when knees are cemented to the bone, theoretically over many years, then that cement bone interface may loosen. For some younger patients, we are doing cementless knees, where again, it's the same press fit technology, and that potentially has a longer longevity as well.
Okay, next question is, I noticed you did not use sutures or staples in closing. What are the main benefits to not using?
Yeah, so I had a slide up there. So the main benefit for me, so there are sutures underneath. So when we close the muscle layer, when we close the fat layer, there's multiple layers of sutures underneath. And even just below the skin surface, there's a thin suture layer. But on top of the actual skin, we prefer not to use staples or stitches, because that way we don't have to do any kind of wound care. So when that glue membrane is applied to the incision, that's it. It stays on like that. It's undisturbed, untouched for 2 weeks until we peel it off in the office for the first post-op visit. So that means that there's less chance for bacteria to get into there. It's just a much cleaner way of doing it. You don't have to rely on the patient or a family member or a nurse to come by every day and change the bandage, where you're exposing it to the air, exposing it to bacteria. You don't have to worry about sterile technique. So it just cuts out a lot of the variables. Secondly, it also allows the patient to shower right away. So if you had traditional gauze bandages, you would not be able to shower with those on. You'd have to put a plastic bag or a trash bag around your leg to keep it covered up. So this allows patients to shower without any kind of covering over their incision. And lastly, I think it also makes for a more cosmetic incision, because you don't have these train track marks along the incision from where the staples and the stitches used to be.
Great. Next question we have is, in hip replacement, is there a lot of blood loss, and do you need blood transfusion?
Great question. So in years past, there was a higher transfusion risk with hip or knee replacements, more so with hip replacement, because with the knee replacement, you do it under a tourniquet, so there's really no bleeding during the surgery. You really can't put a tourniquet around someone's abdomen and cut off blood supply to their hip. So, but one of the main things that we do now is, in addition to the spinal anesthetic, which cuts down on blood loss, we also give a medication called tranexamic acid, and that has really revolutionized blood loss in hip and knee replacement surgery. So it's almost unheard of to require a blood transfusion after an uncomplicated primary hip or primary knee replacement. So this medication that we give it twice. We give it right before we start the surgery, and again right when we're about to close the incision. That medication dramatically cuts down on bleeding. And how it works is it basically prevents the blood in the surgical field. Like it'll start to clot off when you have bleeding, to stop the bleeding. It prevents that anti-bleeding clot from being broken down. So it really kind of stops the bleeding at the source, and it has really decreased bleeding to a point, like I said, that it's unheard of to transfuse somebody at this point for an uncomplicated first-time hip or knee replacement surgery.
Great. Next question is, do you do knee replacements on morbidly obese patients?
Right. So again, great question. I think morbidly obese is obviously a moving target in a relative term. Some insurance companies have put a kind of hard stop on patients who have a BMI of 40 or above. They'll say no. I think I'm much more forgiving when it comes to knee replacements. I think if somebody is morbidly obese and they want a hip replacement, that's a little bit more of an issue because, again, with a big abdomen, that's going to be hanging over that hip incision. It's going to be more difficult, and it's going to increase the risk of infection. But even in a lot of larger patients, when you look at their legs, by the time you get to their knee is actually not really that big. And so I've done knee replacements certainly on people with BMIs of 45 or over, and they've actually done very well.
Great. Next question we have is, are there any work restrictions from replacements, both hip and knee?
So work restrictions, no. In terms of the work restrictions, I basically tell patients, as soon as the hip or the knee replacement is in your body, it is as strong as it's going to be, essentially. I mean, it is ready to take whatever pounding you're going to put on it. The only limitation that keeps a patient from going back to work, whatever their work is their functional recovery. So however long it takes for them to get their pain under control, regain their muscle strength, regain their balance, their coordination, their endurance to a point where they can do their particular job. I don't have any, they can go up and down ladders, they can climb up and down, they can lift heavy weights. That's one of the major misconceptions about hip and knee replacement is that you can't lift anything heavy, and that's not true. Lifting anything, even heavy, in a controlled manner is really not going to do any harm to a hip or a knee replacement. Now, the one thing that potentially could do harm is impact loading. So if you're jumping down a lot, that instantaneous pounding is probably not recommended after having a knee replacement. So I guess if you're professional basketball or football player, you probably shouldn't go back to doing that after having a hip or knee replacement. But I think for more civilian jobs, I think pretty much everything is okay.
All right. Next question says, isn't there a law that surgeons should be using different companies for implants?
It's not really a law that you should be using different companies. Certainly, a surgeon is free to use whatever implant they feel comfortable with. And I think where it got muddy was, there are certainly anti-kickback laws, right? So you can't be getting paid by the company as a kickback to use a particular implant. That's highly illegal. But if a surgeon feels that brand A, B, or C is best in their hands, they can use that exclusively or not. And so, that's how most surgeons pretty much will use just one vendor for their hips or their knees. I sometimes mix it up just to have familiarity with more than one system, but you'll find that most surgeons, hip or knee replacement surgeons, just are very monogamous in that manner.
All right. Next question we have is, in which cases will you definitely go with posterior approach and hip replacement? And do you recommend for these cases to be done in the hospital? Do they need to be admitted / 23 hours OBS, if so?
Great question. So as I said in my talk, pretty much anybody who has, quote unquote, a virgin hip, who that's never really been operated on, that just has regular arthritis, can be done through an anterior approach and can usually be done at the surgery center, provided that they're an appropriate patient medically and physiologically. So the times that I will have to go posterior is typically if it's a revision, so it's a redo operation where the hip replacement has failed for any number of reasons. Either it's infected or it's dislocating or the implants are loose or there's some other kind of a problem that needs to be addressed. Or if they've had previous trauma and they have previous implants that need to come out through the posterior approach, then I'll have to do a posterior approach. So by definition, in my hands, when I'm doing a posterior approach, it's because there's something really abnormal that I can't do an anterior approach. So by definition, those are going to be your much more complex and difficult cases. So for me, by definition, if I'm doing a posterior approach, it's for a more difficult case. And so those are typically going to be done in the hospital. And then how long the patient stays in the hospital really depends on the patient. So even if I had a complex case and the patient's a rock star and has minimal pain and is walking around in the recovery room, then I still have no problem with them going home the same day. But usually these are bigger cases. You're going, if it's a redo operation, you're going through scar tissue. You may have to remove old implants. You may have to cut the bone. So those patients realistically are going to be in the hospital at least a day or so.
Right. Next question is, what is the post-op plan for total knee?
Right. So number one, no restrictions. So we want patients walking as much as they want, as much as they can from day one. With knee replacements, the number one goal in the first 6 weeks is range of motion, range of motion, range of motion. So we want them to be able to get their knee fully straight. And so that typically means when you're lying down on your recliner at home or lying in bed, instead of putting pillows underneath your knee, which will cause it to flex, you want you to put pillows underneath your ankle that will force your knee fully straight. That's usually the hardest thing to get back, is the knee to get fully straight, because when you have a knee replacement or any kind of knee surgery, there's going to be swelling, there's going to be some internal bleeding to some extent. It's going to make the knee very tight, and you're going to want to kind of let it bend a little bit so it kind of makes it looser. You got to fight that and get it fully straight, because if your knee is stuck with a flexion contracture, you're going to not walk normally. So once you get your knee fully straight, then you start working on your own or with physical therapy to start bending the knee more and more, getting more and more flexion, at least 90 degrees right away, and then more and more and more as much as you can go. And then secondarily is regaining the muscle strength in your quadriceps. So we don't cut the muscle during the knee replacement, we cut next to it, but just because of the surgery itself, the quad becomes pretty atrophied after a while, and it takes a lot of exercises, whether it's straight leg raises, leg extensions, leg press in the gym, to really rebuild that quad muscle. So those are the primary goals of the post-op plan for knee replacement surgery, constant icing, elevation for swelling. And then beyond that, whatever the therapist feels is appropriate. Some people use ultrasound, massage. Those are things that are all fine in my book.
Great. Next question is, it seems like there's a dynamic shift happening to the outpatient center for joint replacement. Do you foresee doing more surgeries in an outpatient setting than the hospital in the future?
So I think it depends on your practice mix. So, I'm a little bit unique in that I practice both orthopedic trauma, which is complex fracture surgery, as well as hip and knee replacement. So I think for complex fractures, someone comes in all banged up off of the freeway, those patients will still need and will go to the hospital. Complex revision surgeries will go to the hospital. Complex reconstructions will go to the hospital. So if we're just talking about the patient who has nothing else wrong with them, coming in for an isolated primary hip replacement or primary knee replacement, there's going to be a dramatic shift to the outpatient arena. This year, Medicare finally allowed Medicare patients to be done in a surgical center for total knees, and that's probably going to happen for total hips in 2021. And so once that happens, I think within 5 years, it's going to be rare, unless a patient is sick, that you're going to see a first-time primary hip or knee replacement being done in the hospital. And again, geographically, some places may be quicker adopters. Us at Cypress Creek, we plan on being a very early adopter and kind of leading the way. And Medicare is also pushing that way too. So when you look at Medicare, they're cutting, right? They're cutting, physician reimbursement for these procedures. They're cutting a bunch of other things, but they're actually increasing the payment to surgery centers for these outpatient total hips and knees. So Medicare is actively pushing these cases to the outpatient arena because it will save money for the healthcare system overall.
Great. And our last question of the night is, do you perform revisions of total knee replacement?
Yes, I do. So typically we are doing these, we get a lot of referrals from the community where patients send in complicated cases to us that no one else really kind of wants to take on. So typically we get knee revisions because of infections. So we just did 2 in the past 2 days where we had to take out the implants and put in an antibiotic spacer as a first stage before re-implanting the knee. As a trauma specialist, I do a lot of revision knee replacements for fractures, so for periprosthetic fractures. And then oftentimes we get patients that have loosening or other types of failures of the knee replacements. So we are doing revision knee and revision hip surgery. Just obviously that's not going to be done in the surgery center setting.
All right. Well, at this time, we're going to conclude the webinar. We would like to thank everyone for having participated. Definitely, you guys were asking really great questions and being very engaging. Again, just a reminder that the program evaluation link needs to be completed within 24 hours in order for you to receive your CEU credit. The key phrase is sports medicine, which will go under question number 12 in the program link. If you guys have any questions, you guys can feel free to email me at camador@mhs.net. Again, my email is camador@mhs.net. And
thank you, everybody. Have a great night.
Have a good night.
Thank you.
Thank you so much. Have a good night.
You're welcome, guys.